Welcome to this webinar series. This is our fourth webinar for the year. This is also the beginning of planning for next year. And we just gave everybody another 1 minute because PM was speaking earlier on. And the focus, remember, is still on our seniors. And it's appropriate that today's topic is also about our seniors. So today's webinar theme is about surfing to look after the silver years, especially for our seniors, and how we can, as cardiologists and geriatricians, partner together to work better for our patients. So next slide, please. So just go to a brief overview of what we're going to have today. Firstly, we'll have Dr. Jeanette Ting from NUHS. She's going to give us an overview of geriatric cardiology. And then we'll have Dr. Lim Chun Pin. He will speak to us about red flags, about how we can detect patients with early disease of especially this ATTR cardiomyopathy, a new kind of disease that we can now manage and treat. And Dr. Chawan Sien will give us an update on the diagnosis and how we can diagnose this accurately. And then we have a big panel of experts here, Dr. Carol Tan, Dr. Chong Mei Sien, Dr. Matthew Chen, are all very experienced geriatricians. And we also have Dr. Lin Wei Chin, Dr. Yu Min Sen, as well as Dr. Ho Kei Woon in the team as well. So we have a very exciting cast of experts here to look after you today and to answer as many of the questions you have for us. So for the housekeeping rules, as previously mentioned, we will be having points for this. So for Singapore registered physicians, nurses, and pharmacists, once you've attended and connected throughout the whole duration of this talk, you'll be awarded the necessary points. And please use the QR code to try to get your points for this event. And this last few webinars have been really successful because of the interaction. And just remind you that there is a Q&A box right at the bottom of the screen once the event starts. Feel free to put in these questions, and the panelists will try to answer them as much as we can. And the event is all yours now. So I'd like to first introduce Professor Po Kian Keong. He's our very, all of you know him very well. He's now in charge of the International Assembly of International Governors, a very high position to look after the interests of all the cardiologists under the ACC chapter. And we'll have him introduce the first speaker.
Thank you. I have some slides to show. Can Cherin allow me to share some slides, please? Yes, so the ACC Singapore chapter has done really well under the leadership of Dr. Edgar Tay. Is being given the title of Distinguished Chapter. And over this year, Dr. Tay has organized 4 webinars every quarterly. The first one was on tricuspid regurgitation, second was on lipids, and third was cardio-onco, and now we have this very, very relevant webinar. So I would like to encourage all cardiologists and those interested in cardio to join the American College of Cardiology. From medical student to retirement, we will look after you. And actually now it's complimentary membership for anyone below 40. That will be a majority of you. You have a chance to read the journals. Now there's Jack Asia as well as the Mother Jack journal, Jack Imaging, Jack almost anything. The latest is Jack Advance, which looks at including geriatric cardiology. You can connect and collaborate with people, and there are, besides this kind of webinar, there are also regional webinars and also regional education. I would also like to emphasize on this app, which is more for the primary care physician, is if you can go to NCD Academy at acc.org and download this app. This is from the American College of Cardiology, not only cardiovascular disease, but also covered cancer, respiratory disease, diabetes, and mental health. So without further ado, let's welcome the first speaker, which is Dr. Jeanette Ting. She's an expert, and let's welcome her. Thank you.
Thank you, Professor Poh. Just share my screen. Okay, first of all, thank you to Dr. Edgar and Professor Poh and the Singapore Cardiac Society for giving me the opportunity to share some insights on geriatric cardiology, specifically on aortic valve disease. So I'll just jump right in. So today I'll just share a little bit about the, first of all, start with what's unique about the elderly population. In Singapore, we call them the silver generation. Then I'll discuss briefly aortic valve disease in the elderly, and then go through in brief the valvular heart disease guidelines, the European and American guidelines pertaining to the elderly. And I'll close off with just a few studies that are relevant to aortic valve intervention and valvular heart disease in the elderly. Okay, so when we talk about the elderly, we cannot run away from this term frailty. And I believe the word frailty is a term that is oftentimes used quite loosely, but what exactly is frailty? Before I go to that, let's just look at the average life expectancy in Singapore. So these are some statistics that I managed to pluck out from the internet. So the average life expectancy in Singapore this year is, in 2021, is 83.8 years old. And there's been a steady increase, you can see from this graph, from the 1950s, and is expected to continue to increase. And so by the year 2080, the average life expectancy in Singapore is expected to hit 90 years old. And so if you look at the average life expectancy and the aging population, how are we going to reconcile with the fact that as we grow older, as population grows older, there will be a heavier, greater burden of valvular heart disease in the elderly population? So the word frailty, so what does frailty encompass? So essentially it's a complex clinical syndrome of impaired physiological response and a decreased ability to recover from stressors. And it causes a difference between an individual's biological and chronological age. And therefore stressors such as heart failure or cardiac surgery can cause certain imbalance and disruption in the individual's hemostasis. And studies have shown that frailty is more apparent in females and also in residents of long-term care facilities. And it's also 3 times more common in those with heart disease compared to those without. And frailty is a common predictor of the need for institutional care and mortality up to 1 year after even a successful transaortic valve surgical procedure. So aortic valve disease in the elderly. So rheumatic heart disease has declined in the Western world and is gradually being replaced with greater incidence of degenerative valve disease. And it is estimated that 1 in 8 adults over 75 years old have now at least moderate to significant valvular disease, even if they are asymptomatic. And the commonest ones are aortic valve stenosis and mitral valve regurgitation. So not forgetting our regurgitant, the regurgitant portion of the aortic valve condition as well. So you can also have chronic aortic regurgitation in elderly patients that oftentimes results from hypertension and calcification-related aortic stenosis or bicuspid valve disease, aortic valve disease resulting in ascending aorta dilatation. So this is just a pictorial diagram to illustrate the aortic valve, the location of the aortic valve. So it's tricuspid, and focusing on the elderly. So the top left-hand corner of this diagram on the right shows that degenerative calcific aortic stenosis is what's relevant and common in the elderly, especially in those above the age of 70 years old. So this article, this review article published in 2018, looking at the valvular heart disease in the octogenarian population, shows that quality of life is an important consideration when we look at treatment decisions in this age group. And more patients in this age group are receiving transcatheter therapies with the transcatheter approach, and the advancement in this technology having gaining a lot of momentum in the past 10 to 20 years or so. So in this paper, they also looked at the importance of the various factors in making a decision as to how to manage a patient's valve condition better. So interaction between the patient, the family, and the heart team, looking at what is the surgical mortality, morbidity risk, what is the patient's baseline functional status, what are our goals of therapy, does the patient have concomitant coronary artery disease or other valvular heart disease, and of course, how old is the patient, what is their cultural value, what are their cultural backgrounds, and importantly, what is the likelihood of success with a transcatheter valve intervention. So balancing the goals and benefits versus the risk will help the physician and the patient and their family come to formulate a management plan that will be optimal for each individual patient. So just going through some valvular heart disease guidelines that I'm focusing on the elderly population. So this is the European ESC just came up with the very latest guidelines on the 2020, just this year alone, incorporating and also re-emphasizing the role of transaortic valve intervention in patients with severe aortic valve stenosis. So if you just focus your attention on the bottom gray boxes below, so in patients with who are below the age of 75 years old or who are at low risk for surgical valve intervention and who are not suitable for transfemoral transcatheter valve intervention, these are patients that will qualify for surgical valve intervention, and this is a class 1 indication. Conversely, for those who are 75 years and above, or who are those who are not ideal surgical candidates and are deemed to be suitable for transfemoral approach of the transaortic valve intervention, these are the patients that are deemed to be class 1 indication for transaortic valve intervention. The American guidelines are updated last year. So looking again at those patients with severe aortic stenosis. So if they are symptomatic, of course, symptomatic severe aortic stenosis is an indication for aortic valve intervention. With those without symptoms with aortic stenosis, it will depend on whether or not they have what stage they are, either stage C or stage B. And if their heart function, left ventricular ejection fraction is less than 50%, or if they're going for other heart surgery, other cardiac surgery, then they will qualify for aortic valve intervention. But which one do we choose, surgical or transaortic approach, transcatheter approach? So again, this is a bit of a busy slide, but if you just focus your attention again to the bottom boxes below. So again, American guidelines incorporate the use of the patient's age, and importantly, looking at this STS score as well as their frailty measures and any organ systems are affected. Does the patient have any underlying comorbidities that will affect the choice of whether or not the patient is a surgical or transcatheter candidate. So age, if you look at the bottom, there's a bit of an overlap between the two in the middle box, age 65 to 80, either surgical or transaortic or transcatheter approach is a class 1 indication. But once you see the age above 80, transcatheter actually is a class 1 indication, whereas surgical approach became a 2A indication. So transcatheter versus surgical approach in an elderly population, the transcatheter approach has been found to provide survival benefit over medical therapy. And the transcatheter approach was also found to be non-inferior to surgical aortic valve replacement in high-risk patients. The core valve high-risk trial has shown that the transaortic approach, transcatheter approach was superior to the surgical method in terms of mortality and stroke at 2 years. So from the two guidelines that I showed earlier on, the American and the European guidelines, the indication for intervention is based primarily on symptoms or their ventricular systolic function. However, some patients might benefit from earlier intervention if they have significantly abnormal exercise stress testing or raised biomarkers such as proBNP, which is often used as a prognostic marker as well, or if the patient has a rapid progression of the valve disease or in the presence of very severe stenosis. So this is just a pictorial diagram to show some of the transcatheter aortic valves that have come up in the recent years. So you have on top is the balloon expandable Edwards Sapien valve, and the bottom ones are the self-expanding core valve system, so the Evolut R and the Evolut Pro. Okay, so just a couple of slides on some studies that have been done on aortic valve intervention in the elderly. So the partner trials, which some of us might be familiar with. So these are the landmark trials that looked at the comparing transcatheter approach versus surgical or standard medical therapy. So in the partner 1A trial, they looked at high-risk patients undergoing either procedures, and they found that the transcatheter approach was non-inferior to the surgical approach for all-cause mortality at 1 year. In the partner 1B trial, they compared transcatheter approach versus standard medical treatment in patients that were inoperable, i.e. extremely high-risk patients. And they found that transcatheter approach was superior to standard medical treatment for all-cause mortality at 1 year. And in the partner studies, in the partner trials, they actually looked at health status, not just the success of the valve implantation itself, but they also looked at health status using the Kansas City Cardiomyopathy Questionnaire. And it actually showed that there was significant improvement from baseline in this elderly cohort post-operatively. In the partner 2 trials, they're actually looking at extrapolating the studies to look at intermediate risk patients. And in the partner 2A trial, it shows that there was significantly lower mortality and disabling stroke in transcatheter population compared to the surgical cohort at 2 years. And the mean age in this trial was 81 years old. In the partner 2 S3I study that is still ongoing, they looked at intermediate risk patients with STS scores of 4 to 8%. And they found that so far the results have shown that there are lower rates of mortality and stroke at 1 year in the transcatheter population. Okay, so this is another study that's actually quite interesting that was done in 2017 by Jonathan Affilello. This chap is actually has got a keen interest in cardiogeriatric patients, and he did this study in 2017 looking at different frailty scales to predict outcomes in patients following a transcatheter or surgical aortic valve replacement. So this study was a prospective study, and they looked at more than 1,000 patients. And what did they do? So they actually compared 7 different frailty scales. So the Fried scale, the Fried Plus, the Rockwood Clinical Frailty Scale, the Short Physical Performance Battery Scale, the Burns Scale, and the Columbus Scale. And lastly, they came up with this tool called the Essential Frailty Toolset, the EFT, which incorporates only 4 components, which is the sit-to-stand, cognition, serum hemoglobin, and serum albumin. And they looked at outcomes of all-cause mortality and disability 1 year after the procedure. So this is a quick overview of what the 4 points entail. So 0, 1, and 2 points are for the sit-to-stand. Cognitive impairment was used on using the mini-mental state examination, or there was a 3-point recall of an item that they would tell the patient. And then they looked at serum hemoglobin. The cutoffs are different for males and females, of course. And then lastly, serum albumin. So then they'll come up with an EFT score, and they looked at how this could predict 1 year mortality for both transcatheter and surgical aortic valve replacement. So what does this study show? So it showed that the frailty as measured by these two was the strongest predictor of death at 1 year, worsening disability at 1 year, and also death at 30 days. And so they again reiterated that frailty is a risk factor for death and disability following transcatheter and surgical aortic valve replacement. And they found that using this 4-item scale actually outperformed the other frailty scales, and that was therefore recommended for use in the setting where a patient is being assessed for aortic valve intervention. So there is actually this app that you can actually download, either Apple or Android, which is available. And it's actually quite good because they actually tell you what are the 3 words ask you to remember, and then sit-to-stand. It's actually a timer on the thing as well. So you can actually put the timer and then say how long did it take for the patient to complete 5 chair rises, right? So it's actually very user-friendly, and it's a very quick tool that can be used in a clinical setting that can help to look at to assess the patient's frailty status. So what is the use of assessing frailty, right? It's actually not just helping in terms of whether or not to proceed with the intervention, but how best to proceed. And it can help to tailor patient care in terms of pre and post-operative rehabilitation, choices of the right therapy, the right access, and the need for general anesthesia. So by using this tool, it helps to, because serum albumin is one of the components in this 4-point assessment. And so even before the patient goes for their surgery, or even in the preoperative stage when we are screening the patient, having the physiotherapist or even the nutritionist, dietitian to come in to assess the patient's baseline nutritional and functional state would be very useful, because this can help to predict, help to assess not just their baseline, but also to determine whether or not the patients post-procedurally, do they need to go for rehabilitation for a short duration of time after the intervention. And so lastly, this population cohort study done in the UK actually looked at the characteristics of valvular heart disease in older patients, older people. And they actually looked at more than 2,500 individuals aged more than 65 years old that were screened in a population care setting using transthoracic echocardiography. And they found that there was actually a major burden of undiagnosed valvular heart disease in elderly people. And of course, the most common valvular heart disease found was aortic valve sclerosis, which was 34%, more than a third of the numbers that were recruited. And also they found that undiagnosed valvular heart disease was 2 times more in the 2 most deprived socioeconomic areas compared to the affluent areas. And of course, 3 times higher in those with atrial fibrillation. And based on this data, they found that the prevalence of clinically significant valvular heart disease was estimated to double before 2050. So in summary, frailty, I wouldn't say should be incorporated. I think it would be, must be incorporated in the assessment and management of the aortic valve disease in the elderly. And it's important not to just use an eyeball test, which is what was previously used, stand at the end of the bed or at the end of the chair, and just look at the patient and estimate how good their condition would be in terms of their frailty. And so using certain scales, I think some of the drawbacks of some of the scales is that they are very comprehensive, and they are quite tedious to go through all the questions. But using the EFT that was shown earlier is actually a good screening tool, and it's a quick one as well, which can be used. Of course, a shared decision between the heart team and the patient, and very importantly, being aware of the patient's social well-being. A lot of issues such as depression, neglect, isolation, a lot of elderly live on their own, issues with taking medications, polypharmacy, all these needs to be addressed and should be incorporated in our assessment of the elderly when we are planning for valve intervention, or even just managing their condition, even if it's conservatively. With that, thank you very much.
Thank you very much, Dr. Ting, for the excellent talk. I certainly learned a lot beyond aortic stenosis. Our next speaker is Dr. Lim Chun Ping. I definitely enjoy very much speaking to him pre-pandemic in the conferences such as the ESC. He's a role model father. He's also an excellent cardiologist, and he gave a very impressive faculty contribution to the ACC Asia. And today, he's actually at Mount E in the Heart and Vascular Clinic. And today he's going to talk about raising awareness for early detection of amyloid cardiomyopathy. So without further ado, Dr. Lim, thanks.
Thank you very much, Prof. Po, for that very kind introduction. Yes, without further ado, I'd like to wish everybody a good afternoon, friends and colleagues, and a very big thank you to Singapore Cardiac Society, Prof. Po, as well as Edgar for the kind invitation to speak with you on transthyretin amyloid cardiomyopathy. These are my disclosures, and I would like to start by asking all of you a question. How many of you have a patient with cardiac amyloidosis? Well, yeah, these days on Zoom, I really can't see how many of you are raising your hands, but I would presume that it's probably at most a handful of you. And so some of you might be wondering, why are we talking about such a rare disease? Now, let me frame the question a little differently. how many of you have an elderly patient with lower limb swelling, shortness of breath on exertion, heart failure with normal or near normal ejection fraction, carpal tunnel syndrome, postural dizziness or hypotension? And how about lower limb pain, numbness, and weakness? And I think once I ask you the question this way, more of you might be raising your hands, and I will then go on to tell you a little bit more about why these are actually relevant things that you should think about when you see your patient. Now, I'd like to share with you a story that was published in the New York Times in 2013. And this was shared to me by my good friend and fellow heart failure cardiologist, Dr. Ku Chun Yuan. So this is a story about a man with a green heart. Okay, this was a 76-year-old man with the usual comorbidities of diabetes, hypertension, hyperlipidemia. And 2 years ago, while attending a friend's wedding, he developed diarrhea. He was treated with multiple courses of antibiotics, and even after endoscopic evaluation and months of blood tests, the cause of the loose stools remained unclear. Subsequently, the diarrhea eventually subsided. Now, he also developed bilateral hand numbness, and his fingertips would often hurt or bruise when he used them. And following investigations, he was deemed to have bilateral carpal tunnel syndrome. So he was recommended to undergo surgery for this. Then during his pre-op assessment, he was noted to have an old infarct on the ECG. So he then recalled that he was easily out of breath and noticed some intermittent swelling in his lower limbs. And further workup revealed that he had triple vessel disease. So he was recommended to undergo a coronary artery bypass operation. And at the operation, the anesthetist noticed that the patient had a large tongue and intubation was actually difficult. And upon opening the chest, the cardiac surgeon actually noticed that there was a green hue in the right upper section of the heart. And this was the first time he has seen something like this in his many years of doing bypass surgery. Now, to cut the long story short, the bypass operation was a success, and the biopsy of the heart revealed that the patient had cardiac amyloidosis. And he was later worked up for the cause and found to have primary amyloidosis, or what we know as AL amyloidosis these days. And this was the story of the man with the green heart. Well, cardiac amyloidosis is often misdiagnosed and underdiagnosed because of a variety of physician-related and disease-related reasons. Now, these include the perceived rarity of the condition, and it is it's fairly uncommon if you think about it, and when you compare it to conditions like ischemic heart disease or heart failure with reduced ejection fraction. But with better understanding of the condition, we realize that it is actually more common than we had previously thought. There is also a variety of ways and severity of presentation of this condition, and hence makes the diagnosis a bit difficult to do with confidence. Also, there's fragmented knowledge among the different specialties and subspecialties, shortage of centers and specialists dedicated to treating this disease. And until lately, this has been a condition that was difficult to diagnose without histological confirmation with a cardiac biopsy. Yet the diagnosis of cardiac amyloidosis early is very important because the outcomes of cardiac amyloidosis are largely driven by the severity of cardiac dysfunction, especially at the point of diagnosis. And emerging therapies aimed at preventing this further amyloid deposition is available these days. Now, amyloidosis is characterized by organ dysfunction as a result of the deposition of misfolded precursor proteins that form the cross-beta sheet amyloid fibrils. And these abnormal misfolded precursor proteins are deposited in the extracellular spaces. And cardiac amyloidosis occurs when these proteins are deposited in the heart, therefore resulting in a very stiff heart with predominant diastolic dysfunction more than a systolic dysfunction. There are more than 30 known amyloidogenic proteins. They can be hereditary or non-hereditary, but the cardiac amyloidosis arises from two major causes. One is the immunoglobulin light chain aggregation, also known as AL amyloidosis, and two, the misfolded transthyretin, resulting in an ATTR cardiomyopathy. And there are many others, including AA amyloidosis, but the first two, AL amyloidosis and ATTR amyloidosis, actually account for more than 95% of all cardiac amyloidosis diagnoses. Now, I would like to spend some time explaining what this condition is so that you have a better understanding. And AL amyloidosis results from a misfolding of overproduced immunoglobulin light chains. It can be kappa or lambda secreted by abnormal plasma cells, such as those in multiple myeloma. It is uncommon, but there are about 3,000 new cases in the US, and the heart is involved in about 50 to 75% of these cases. Unfortunately, in Singapore, we do not have the data on the incidence of cardiac amyloidosis. And the organs that are commonly involved include the gut. Then patients will develop some malabsorption symptoms, the kidneys, renal dysfunction, the liver, as well as the nerves. They get a bit of an autonomic dysfunction. So, but the survival of the patients is largely again determined by the degree of cardiac involvement. And by the time heart failure occurs, the median survival is actually only 6 months, even with successful treatment of the underlying hematological problem. Now, the mainstay of treatment for AL amyloidosis is still chemotherapy or bone marrow transplant. And for the patients with advanced heart failure, a sequential heart transplant and a bone marrow transplant is the treatment of choice. Now, the other major cause of cardiac amyloidosis is the misfolding of transthyretin. Transthyretin was formerly known as prealbumin, which is produced by the liver, and it serves as a transport protein for thyroxine as well as other proteins in the body. Now, the formation of TTR amyloid fibril requires the dissociation of the tetramer of the beta sheets into alternatively folded monomers. And then these reassemble, and then they form insoluble amyloid fibrils that can be deposited in the various organs. Now, the TTR amyloidosis can be due to the wild type. That means there's no mutation involved, and is also otherwise known as a senile cardiac amyloidosis. And there's also the hereditary type, which is the hereditary genetic variant of TTR. For the elderly senile wild type amyloidosis, we do not really know why the proteins suddenly become kinetically unstable and they aggregate, but it seems to involve the aging process. So TTR amyloidosis can also involve the other organs, but in particular, the hereditary type tends to involve more organs than the wild type. So now the hereditary, the gene coding for the hereditary TTR cardiomyopathy is in the V122I, which is found in about 3 to 4% of the African Americans. It's inherited in the autosomal dominant fashion with variable penetrance, and the median age of diagnosis is 69. So in the age group of where they may appear in their geriatric years. And the median survival after diagnosis is between 2 to 5 years. A little bit less common in Singapore, but more common is really the wild type ATTR amyloidosis, which usually presents as a restrictive cardiomyopathy, which means the heart is very stiff, and usually it occurs in the elderly. In fact, up to about 25% of patients 85 years and older show the ATTR wild-type amyloid deposits on autopsy studies. And it is found typically in males above 60 years old. And in addition, it is more common than previously thought, and it is likely underdiagnosed. And usually it's probably more common amongst the patients with heart failure with preserved ejection fraction, as well as those with a calcific aortic stenosis. And median survival from the time of diagnosis is 3.5 years. The treatment of ATTR cardiomyopathy is beyond the scope of this talk, but it briefly includes heart liver transplantation for the hereditary type. And finally, these days, we have the treatment of tafamidis for the treatment of wild-type ATTR. Now, the cardiac amyloidosis is typically difficult to diagnose. Fortunately, there are many suggestive findings in the clinical presentation. Cardiac imaging, as well as a lab tests. And these together often gives us signs that can be suggestive of the condition, raise our suspicion, and facilitate early as well as a timely diagnosis. Now, in terms of clinical manifestations, we have cardiac manifestations, non-cardiac manifestations that we should pay attention to, and there are also some soft signs in the patient's history that will raise our suspicion. Now, the cardiac manifestations include the typical heart failure signs, patients presenting with shortness of breath, usually on exertion, and I think you won't miss this. Patients may be fatigued and feel weak. Lower limb extremity may be edematous. The patients may have ascites with reduced exercise tolerance. Other cardiac manifestations include cardiac conduction abnormalities like atrial arrhythmias such as atrial fibrillation, bundle branch blocks, and a complete heart block on their ECG. The patients can present with chest pain with normal coronary arteries, but when we assess them, they may yet present with a diffuse myocardial ischemia. Patients often have aortic stenosis in the elderly, and on ECG, they may have a pseudo-infarct pattern, and I will expand on this in a little while. There are also non-cardiac manifestations because of the deposition of amyloid in the rest of the body. So they can, for the wild type, we should look out for symptoms such as a bilateral carpal tunnel syndrome, atraumatic biceps tendon rupture, as well as the symptoms of lumbar spinal stenosis. For the hereditary ATTR amyloidosis, they often present with more widespread organ deposits. So they usually present with purpura, as well as they can also present with bilateral carpal tunnel syndrome, as I've mentioned. The eyes can have some manifestations. Liver can have hepatomegaly, some kidney involvement. GI symptoms predominate in patients with ATTR, hereditary ATTR amyloidosis, as well as they often get a peripheral neuropathy and autonomic dysfunction. Now, there are also red flags that we should try to pick up in terms of clinical symptoms, such as patients who are intolerant of standard heart failure therapies, patients who are more than 60 years old with heart failure with preserved ejection fraction, with a history of carpal tunnel and spinal stenosis. The diagnosis of hypertrophic cardiomyopathy in the elderly patient should point us towards whether they may actually have amyloidosis instead of a hypertrophic cardiomyopathy. A family history points to a hereditary ATTR, if they are African American, which we seldom see here. Also, sorry, back to the part where they are intolerant of standard heart failure therapy, those patients who used to be hypertensive, and now you realize, hey, the blood pressure seems to be coming down, they have a thickened heart muscles, but yet the BP is coming down, they require less and less blood pressure pills. These are things that point towards ATTR cardiomyopathy diagnosis. Now, in terms of imaging, we can look at the ECG, the echocardiogram, as well as a cardiac MRI. And in terms of ECG, so patients are expected to have left ventricular hypertrophy on echocardiogram when they have cardiac amyloidosis. But on the ECG, instead of an LVH, we actually see small voltages, and therefore we call it a discordance between the LV thickness versus the QRS voltage. Now, the other signs include low voltages throughout a pseudo-infarct pattern, so you start seeing some Q waves in the anterior as well as the inferior leads, and poor R wave progression on ECG. Now, patients can present, so the typical ones that the medical school teaches us is patients who have LVH on ECG, yet poor R wave progression, but 70% of them actually present with a pseudo-infarct pattern on ECG. Patients may also have a conduction disease, and 22% of them actually present with some form of an AV block. So on echocardiogram, this is we actually can diagnose or suspect cardiac amyloidosis, and I'm sure Wan Xian will explain to you a little bit more, but just a quick one. On the top panel, you see a normal echocardiogram, short axis view of the LV, and on the right hand side, you see a parasternal long axis. And you see that the left ventricle is contracting very briskly and relaxing very briskly, and the left ventricle myocardium is actually very thin. Now, on the bottom panel, you actually see a hypertrophic left ventricle with this kind of a speckling kind of appearance of the left ventricle, and the relaxation visually looks a little bit slower. We have this capability of doing a global longitudinal strain these days, and if you do look at a bullseye plot of a global longitudinal strain, the normal will be red throughout, as you can see over there, but the bullseye plot on a patient with a cardiac amyloidosis shows a cherry on top pattern, which is very typical. And this is a typical pattern of a cardiac amyloidosis presentation on a global longitudinal strain on echocardiogram. Now, other echo red flags includes a thickening of the AV valves and the interatrial septum, a pericardial effusion, as well as a significant diastolic dysfunction and a speckled granular appearance of the myocardium. Now, I will not cover the MRI part in detail, but I think Wan Xian might tell you a little bit more about that. And last but not least, in terms of biomarker clues, we know that biomarkers can point us towards the suspicion of cardiac amyloidosis. If a patient had a chronic, low-grade, persistent, elevated troponin T or I for that matter, if they had a chronically elevated NT-proBNP level, and we should suspect a cardiac amyloidosis. Otherwise, there are also other lab tests that we want to do to rule out AR amyloidosis. If we have already diagnosed cardiac amyloidosis, we will do a serum free light chain ratio, as well as we can also do the serum and urine immunofixation. Therefore, in summary, I would like to take away I would like you to take away this mnemonic that will help you suspect the presence of a cardiac amyloidosis in the patients that you see in future. The mnemonic is hidden. Hidden meaning H for HFpEF, patients with heart failure with preserved ejection fraction, typically over 60 years old. Intolerance of standard heart failure therapies or your usual blood pressure pills. A discordance between the QRS voltage and the LV wall thickness on echo. The diagnosis of a carpal tunnel syndrome or lumbar spinal stenosis in your elderly patient. Echo showing increased LV wall thickness, and if they have a nervous system involvement as well, autonomic nervous system kind of symptoms, we should then suspect cardiac amyloidosis. And with that, I'd like to thank you.
Thank you very much, Chun Pin. That was an excellent presentation. I mean, you've just a short span of a couple of minutes, you've actually showed us all the important red flags that we need to be aware of. With that, I'll transit to the next speaker, Dr. Chan Wan Xian. I know her for many years already. She's an excellent clinician, and she's trained in Toronto in heart failure and advanced heart failure management. So she's going to talk to us about how to accurately diagnose this condition of cardiac amyloid. So Wan Xian, please.
Thank you. Thank you, Edgar, for the kind introduction, and thank you, Singapore Cardiac Society, Edgar and Prof. Po for the kind invitation to deliver this talk. Let me just share my slides first. Okay, right. Thank you, Chun Pin, for starting off with talking about this ATTR cardiomyopathy. So I guess some of my slides may overlap, but I'm going to jump and focus more straight into the approach to this diagnosing ATTR cardiomyopathy. There we go. So ATTR cardiomyopathy, as Chun Pin has very nicely and in detail explained, it is a condition when this transretin plasma protein, when it becomes unstable and it starts to accumulate in the myocardium. So briefly, ATTR cardiomyopathy is divided into the wild type and hereditary, and Chun Pin has already gone through to differentiate these two subtypes for ATTR cardiomyopathy. To briefly just go through it, wild type is the more common one. It happens in the more elderly group of patients. And the true prevalence of this condition is not entirely sure, but based on autopsy studies, actually quite a large proportion, like 25% of patients over 80 years old in the elderly group has got a wild type TTR diagnosed on the autopsy or biopsy of patients. And for patients who has undergone actually aortic valve replacement, when they actually look at the non-biopsy approaches to look at this group of patients, about 60% of the patient actually has got ATTR cardiomyopathy. So in other words, it tells us that a lot of times this condition is present and is actually under-recognized and under-diagnosed in our elderly group of patients. when do you suspect ATTR cardiomyopathy? Well, Chun Ping has gone through this in quite a lot of detail. Essentially, elderly patient, when they present to you with symptoms of heart failure, in other words, restrictive cardiomyopathy with symptoms and signs of restrictive cardiomyopathy. So this is the group of patients that we got to be a bit more focused and look and think a bit harder whether we are missing out something like ATTR cardiomyopathy. So in the evaluation of this group of patients, we would typically start off with history, clinical findings that as Chun Ping has gone through in quite a bit of detail. Usually the first step after taking a detailed history and checking out on clinical findings for rhythm issues, heart failure issues is the ECG. So the ECG characteristically, we are looking out for low voltages, which is a mismatch. So we will usually find, unlike the concentric LVH type in hypertensive heart disease, where you see LVH changes on the ECG restraint pattern, this group of patients, when we see them with certain symptoms, and an echo most of the time would have been done, that we see significant LV wall thickness, but on the ECG, there's actually low voltages that's kind of like a mismatch. At the same time, pseudo-infarct pattern, but a lot of these patients actually may not have the typical ECG findings that we have discussed. In fact, only about 25 to 40% may have this, but it doesn't mean that without this ECG, they do not have ATTR cardiomyopathy. So next step, commonly we will usually do an echo for most of these patients when we assess with symptoms that we have described. The typical findings on an echo, the thickness, the LV wall will be very significantly thickened with a speckled appearance. Most of the time, you're looking out for more than equals 14 mm of LV wall thickness. The RV most of the time can be involved as well. Then we see morphology of a restrictive cardiomyopathy type with dilated atrium, increased LV filling pressures. The other things that can watch out on echo would be thickened valves in the echo, thickened interatrial septum. We can sometimes see a slim of pericardial effusion around the heart, and not uncommonly we could see pleural effusion as well. If we go into more assessment on the echo, we could find a possibility of a low stroke volume. And the other thing that can coexist in some patients is a lot of time a low follow gradient aortic stenosis. We usually go into deeper evaluating this group of patients. On the echo, we could actually look at the diastolic function of the echo. Most of the time, we'll find evidence of restrictive LV filling on the Doppler signals. And another thing that is really going to be helpful with this group of patients is looking at the global longitudinal strain of this group of patients. The classic pattern that we have found, though not always found in all patients with ATTR cardiomyopathy, would be a sparing of the apical strain. So usually this is what Chun Ping has shown, cherry on the top appearance, where the basal and mid LV longitudinal strain is affected, whereas the apex is very much preserved. I'm going to then move on to the MRI scan. So once we see these patients and we go through history, clinical findings, and the preliminary ECG echo, and we think that it's suggestive, like we have the features, some of the features that we have described. The next step is actually very important to look into the other causes of restrictive cardiomyopathy to exclude the other conditions that could possibly cause infiltrative cardiomyopathy, to make sure that we exclude hypertrophic cardiomyopathy as a cause, and as well as constrictive pericarditis. So in MRI becomes really quite important at this step of the evaluation then, because MRI actually is able to provide us with more high definition structural imaging, tissue characterization that will give additional incremental information apart from the echo. So for example, in cardiac amyloidosis, in a diagnosis of cardiac amyloidosis, we will be able to find diffuse subendocardia, LGE, late gadolinium enhancement pattern, or transmural, sometimes patchy as well, but most of the time diffuse and transmural type. At the same time, the other one is the T1 myocardial mapping technique. This is the pre-gadolinium before you give the contrast. You could find accumulation of the myocardial signal in the extracellular space, and this is quite useful as one of the signs. In fact, you could actually look at extracellular volume fraction to assess that. The other thing is actually the inability to null the myocardial signal. All this points to a very high chance that there may be amyloid deposition in the cardiac MRI. And we could also use cardiac MRI in this group of patients for predictability of mortality. So in patients who has transmural LGE have really a 5-fold increase in terms of mortality as compared to those without LGE. And as I put it across at the beginning, besides looking for features of cardiac amyloidosis on the MRI scan, it is very useful to exclude the other conditions. So there are typical features on the cardiac MRI that we can find in terms of cardiac sarcoid, myocarditis, hypertrophic cardiomyopathy. So this will be a useful modality that we could employ in patients that we suspect with ATTR cardiomyopathy to exclude these conditions before we clinch the diagnosis. Okay, so once this is done, these 2 steps are done to be sure that we are dealing not with other modality. Next step is actually very important that we assess and exclude monoclonal light chain both in the blood as well as the urine test. It is important that we exclude light chain amyloid cardiomyopathy because the evaluation and the approach subsequently, especially the management, will be completely different. So if we do find presence of light chain, monoclonal light chain, then really we have to initiate a hematological consult. That may involve biopsy of the involved organ and then the tissue typing. And if it's positive, of course, then treatment for light chain amyloidosis got to be quickly initiated, because the earlier that they start treatment, the better the prognosis. If it is negative, then it's unlikely in this case, and then we got to look down the branch of ATTR cardiomyopathy. So briefly here, as I mentioned, light chain cardiac amyloidosis versus ATTR cardiac amyloidosis, treatment is completely different. So we need to definitely forefront in the approach, exclude this condition and start treatment and evaluation if there's a possibility there. Okay, so once we've excluded light chain, monoclonal light chain in this patient group, then now we have a non-invasive way. In the past, when there's a suspicion in this group of patient, the only way is actually an endomyocardial cardiac biopsy. But now we have a non-invasive way. A lot of times in the past, when there's suspicion on this patient, this condition, a lot of patients do not want to actually go through an invasive evaluation like a myocardial biopsy. Now we actually have got the technetium-99 cardiac scintigraphy scan that we could easily do to assess this group of patients. So I'm going to quickly look through. So this modality actually has been around for quite some time. So cardiac scintigraphy to assess patients. In fact, 30 years ago, there are already studies that have demonstrated that with the myocardial uptake of this technetium bone avid radio tracer on the myocardium, it can actually represent cardiac amyloidosis. So this has been actually a known modality about 30 years ago. However, from the studies 30 years ago, really there's variable in terms of the diagnostic accuracies, but it may be because that both light chain as well as ATTR cardiomyopathy has been included in the studies. But lately, this is a study from the 2005 by this group, Rapanzi. So this group of investigator actually found that if you compare patients who has got ATTR cardiomyopathy versus light chain, the patients with ATTR cardiomyopathy, you could see that when they look at heart versus whole body tracer retention, it is significantly higher. And really in the 2000s, a lot of, there are many other studies that's been done to show the high specificity of these tracers for ATTR cardiomyopathy. In other words, if it's done and that is in terms of myocardial retention, then it could be actually used to pick up ATTR cardiomyopathy. I'm going to quickly just go through this technetium cardiac scintigraphy scan. So it has two components to it, a qualitative way of assessing as well as a semi-quantitative. So qualitative way is actually a visual way of grading grade 1 to grade 3. So grade 0 to grade 3. So grade 0 is when there's completely no myocardial uptake when you compare with the rib that's adjacent, whereas grade 3 is when the uptake in the myocardium is actually much greater compared to the bones of the ribs. And then in between, grade 1 the lesser, and grade 2 uptake that is that's equal to the rib. Another way would be actually a semi-quantitative method where you compare the myocardial uptake to a contralateral lung uptake. And if the ratio is more than 1.5, the studies have been shown that it's got high specificity in terms of diagnosing ATTR cardiomyopathy. So this is a study from 2013 where you could see that patients with cardiac with the wild type and the ATTR cardiomyopathy has got really a significantly higher semi-quantitative cardiovisual score, as well as qualitative score when you employ the use of technetium 99 PYP cardiac scintigraphy scan. So with some of these studies that come on in the year in 2000s onwards, then this group of investigators did actually large multi-center study that was done in about 1,200 patients with suspected cardiac amyloidosis. And they found that if you use a cardiac scintigraphy scan, at the same time taking into account the absence, and you check for light chain monoclonal protein, and there's absence of it, you use this approach, it is actually high sensitivity and positive predictive value for diagnosing ATTR cardiomyopathy. So with this study, they actually propose an algorithm so that if the patient, if the patient has got a suspicion in terms of clinical, and the patient has got heart failure with an echo and cardiac MRI finding that's consistent with cardiac amyloidosis, and if the bone cardiac scintigraphy scan using these bone tracers are actually done, and if there is a grade 2 or 3 cardiac uptake, at the same time there's an absence of monoclonal light chain protein in this group of patients, then you could actually use this to confirm ATTR cardiomyopathy, and there's no need to actually go for a cardiac biopsy in this group of patients. However, in patients that actually is, so if we have got a group of patients that the criteria are not met, in other words, if there's a group of patients that has actually gone through the positive PYP, but at the same time the light chain monoclonal antibody is also positive, then this group of patients actually still would benefit from endocardial myocardial biopsy to exclude the presence of light chain. So the indications of endocardial biopsy is still important to employ endocardial myocardial biopsy in the assessment of ATTR cardiomyopathy. So the indications would be if there's a positive bone scan, but at the same time there is presence of monoclonal light chain in the blood or the urine. So this group of patient, when there's some discrepancy, I think this technique would be still advised to use. Or if both cardiac scintigraphy scan, the PYP scan, is negative or equivocal, but clinically you actually suspect that the patient has a heart failure with HFpEF and there's a high suspicion, then this endocardial myocardial biopsy would still be important. Or in some centers, when the bone scintigraphy scan is not available, the myocardial biopsy can still be used in this group of patients evaluation. On the myocardial biopsy, the signs that we will see would be on the H&E staining, you see diffuse amyloid deposition. Then on the classical Congo rate staining, the apple green birefringence on the polarized light microscopy. And then further for typing of amyloid, we could actually employ immunohistochemistry or the mass spectrometry technique. Okay, so once the diagnosis of ATTR cardiomyopathy is clinched, it is actually very important to send the patient for a genetic test. So genetic tests would still really be important for patients with ATTR cardiomyopathy that's diagnosed, irregardless of the patient's age. That's because we need to differentiate a wild type from the hereditary type, especially when the treatment will be completely different. And at the same time, if it's hereditary ATTR cardiomyopathy, then it becomes actually quite important to pick it up early so that you could do family counseling as well as potential screening for the rest of the family members. At the same time, certain type of hereditary type of ATTR cardiomyopathy, the progression may be aggressive, so this group of patients would need closer follow-up as well as management. I'm going to just quickly, although I'm not asked to speak about the management, but just a quick slide, because I feel that it is still important to put this up, because the treatment for, once you actually pick up and differentiate the hereditary from the wild type cardiomyopathy, treatment is different, and as well at the same time, I think why we're discussing this and recently why that approach, there's a lot of discussion on the approach, is because of the availability of the medications. So this comes on really the last couple of years with disease-modifying therapies for ATTR cardiomyopathy, and it's especially because of the availability of the therapies. That's why now the activated kind of the discussion in terms of the approaches with managing and with improving the outcome of this group of patients. So with the treatment, just very quickly. So ATTR cardiomyopathy, the last 3 years ago, 3 to 4 years ago in 2018, was the trial on the tafamidis. So with this medication, now we have actually something that we can use to cut down in terms of reduce the mortality as well as hospitalization for patients with ATTR wild type cardiomyopathy. It actually works on the binding of the TTR tetramer to actually prevent further misfolding as well as deposition. So this medication is actually good for ATTR wild type with cardiomyopathy. For the other groups of ATTR cardiomyopathy, which is hereditary or with any neuropathy involvement, then the treatment will actually involve other medication which is more targeted in terms of the hepatic synthesis. So with that, I would like to conclude my presentation. So ATTR cardiomyopathy is an under-recognized cause of heart failure in older patients. For a long time, there's not been available treatment, and with untreated amyloidosis, a lot of these patients actually ends up in end-stage heart failure with very poor prognosis. But now we actually have got non-invasive imaging techniques that we can actually use to diagnose and clinch a diagnosis for ATTR cardiomyopathy without having to go for confirmatory endomyocardial biopsy. And with that, there's an advance recently with the pharmaceutical therapy for this group of patients that's available now. We're glad that this management for this group of patients can actually have some improvement with this emergence of the medication. So with that, I thank you for listening to my talk.
Thank you very much, Wan Qian. That was very clear again and very useful information on how to diagnose this. And it's heartening to know that you can use non-invasive techniques now to diagnose this. So we're going to move straight on to the Q&A. It's already already past 2 o'clock. So we're just trying to keep to time a little bit. So we'll spend the next probably 10 minutes to go through some of the hot questions that we have on the Q&A. Some have been answered already, but please feel free to type in any more questions that you may have. And I'll hand the mic over to Dr. Jeanette Ting, and she will moderate this session. Jeanette, please.
Thank you, Dr. Edgar. Yeah, there's been some questions that have been asked already, mostly pertaining to amyloid. So actually, I would just like to open up with one question that was asked actually was that should a geriatrician be involved in the assessment of elderly patients with aortic stenosis? I would say yes. Most definitely, but I'm not sure how often this is done, although in the ideal setting, most definitely they should be. So with this question, I would like to direct a question to one of our geriatricians, Dr. Chong Mei Xian. Yeah, how common or how often have you seen amyloid in your own personal clinical experience?
None in 20 years, or maybe I missed it. I'm not sure. Yeah.
But has anyone like referred in terms of
no, I've only had one patient's relative with amyloidosis. So
right, okay.
yeah, but that patient I think went to Mayo Clinic for treatment. Yeah.
Okay.
Yeah.
Thank you.
Yeah.
I think there was one question earlier which I thought was very
yeah, I just thought I wanted to just speak a little bit about the frailty score.
Yes, please do.
And it was quite interesting. So because somebody asked whether geriatricians should be involved, right? So I think of course my answer will be yes lah. Huh? Yeah, because I think it can optimize the condition. So I think when you talk about frailty scales, I think somebody asked what scale, and Dr. Ho said that you do gait speed. So the scale which you presented, which the paper you presented, it was actually doing sit to stand. So sit to stand is more of a power functional strength rather than a gait speed. So I think in the end, the frail scale you choose, it has to depend on what use you have of a geriatrician now, whether it's for pre-op, risk stratification optimization, for post-op rehab, or whether you're looking for long-term outcomes. So if you're actually looking at pre-op risk stratification, I think it can be a very simple scale. I mean, it can even be any of the visual scales we use like frail scale or CFS. But once, or even your EFT, which you presented, that's okay, because I think you're just trying to see which one can go for op. But I think once you go to post-op rehab and long-term outcomes, you are not just looking for a physical, you are also looking for functional as well as a cognitive outcomes longer term. So I think those two components have to be in that assessment. And perhaps you want to have a very simple scale for screening, and then you decide which one you will refer to a geriatrician to optimize, similar to what a lot of hospitals are doing as standard care now in terms of orthogeriatrics as well as perioperative. And personally, I found that a collaborative effort really makes a bigger difference in outcomes than a single specialty directed efforts. Yeah.
Thank you so much, Dr. Chong. Okay, we've had a couple of other questions with regards to the cardiomyopathy, the amyloid. So I think earlier on, one of the answers, I think Dr. Lim Wei Tin mentioned about this treatment. Someone asked about heart failure medication. So I actually want to ask a little bit more about this drug, tafamidis, if I pronounced it correctly. So it's rather costly medication. And so what are your alternatives, or rather other options of treatment that might be more affordable for most of our population, who most of them can't afford expensive drugs? Maybe I can ask Dr. Lim Chun. Yeah.
So until these days, we really have very limited treatment, and I think Wan Xian has very nicely showed that we can, number one, treat the heart failure symptoms with our usual heart failure medications. But I would say the things such as beta blockers, ACE inhibitors, and mineralocorticoid antagonists have very limited role in patients with cardiac amyloidosis. In fact, a lot of them are actually very intolerant of these medications, and they often have postural hypotension, and they usually end up having a lot of side effects of these traditional heart failure medications. More importantly, the mainstay of treatment will really be the diuretics, and really maintaining their fluid balance is most important. Wan Xian then showed us that there are also treatment for the treatment of amyloidosis itself. We can now target the treatment of the underlying pathology. So in ATTR, the treatment is with tafamidis, and in patients with AL amyloidosis, we will of course have to treat the underlying hematological disease. The tafamidis, the mode of action is really, it stabilizes the amyloid fibrils and the transthyretin, and prevents them from disintegrating and therefore deposit as amyloid fibrils. And it has been shown in patients with ATTR cardiomyopathy to reduce the all-cause mortality as well as the heart failure hospitalization. It is costly, and I must admit I haven't had a chance to use it so far. I'm not sure who here has. Maybe Wei Qin or Wan Xian might have used it before, but I haven't had the opportunity. So maybe they can share their experience using this medication if they did.
I haven't had a chance to use it, so maybe Wei Qin, have you used it?
Yeah. I have. I've used a few on a few patients. So they are generally on a compassionate or on a free basis from Pfizer. So Pfizer has given a few patients free usage of tafamidis. Then I have a few patients who are CSC card holders. So essentially we are paying for their medication. So the medication itself, it costs about 30,000, 20 or 30,000 a month Singapore dollars, which works up to about 200 to 300,000 a year, which is out of reach to most average Singaporeans. So that's a pity. It works by tetramer stabilization, as what Chun Pin mentioned, and it has been shown on the ATTR-ACT trial to reduce mortality if you use it long-term after 18 months. So that's a good medication, but because of its cost, it is really very inaccessible. So far, my patients usually don't have much side effects from this medication. Even in the trial, the side effect profile is very, very good with some minor GI disturbance. That's about it. Most of our patients truly cannot afford tafamidis. There are some other off-label drugs that actually can potentially work, and they are under further investigation. One of them is this NSAID called diflunisal, which is not available in Singapore, but we do bring it in from the US. It works in the same way as tafamidis in stabilizing the tetramer. And in small studies, non-randomized studies, it actually has been found to stabilize the cardiomyopathy. So that's an alternative off-label, but lack of further treatment that might be useful. Another medication is our commonly used antibiotic doxycycline. Again, off-label use. In some small studies, they have been shown to disrupt fibrils in vitro, but in patients, patients using doxycycline actually showed regression in their LVH on MRI. So it's potentially useful, of course, lacking RCT evidence, but short of bankrupting the healthcare system, these are some alternatives we can consider.
Okay, I've got one question coming in for the geriatrician. So it's about sarcopenia in these patients with cardiovascular disease. Maybe Matthew or Carol can chime in. How do we improve the patient's, say, a pre-TAVR outcome if the patient's already a little bit sarcopenic? Is there a way to help them prior to the to an invasive procedure, or is there any tips and tricks to help these patients before they actually undertake, say, a transcatheter procedure?
Yeah, maybe I can chime in with this. All my patients have sarcopenia, but one of the things that I have realized that's really important, especially before surgery or any procedure, is to actually assess the nutritional status. I cannot believe the number of people out there who are actually vitamin B12 deficient, not getting protein because they are all elderly and they think that as they get older, they eat porridge and nuts and peanuts. Vitamin D is huge now. We're seeing a lot of that. So before any of my patients go for any procedures, cardiac or otherwise, we actually have to screen. We use a lot of oral nutritional supplements now because they all can't eat, they don't have teeth or whatever it is. And I think that's really, really important. We have seen that in ortho-geriatrics, and we would hope to see that also in cardio-geriatrics or geri-cardio, whatever. But I think that's really important. I've seen that because I see a lot of elderly patients. I once had a 90-year-old lady who had severe aortic stenosis. And then because hers was a medical legal case, so we had to get her better so that she could, sort out her medical legal. And she had severe AS, and she was told, you're too old for go for surgery. And she went through TAVI, and she did really, really well. So now all my patients said, there's no such age as you're not ready to go for an angiogram, or you're not ready to go for a stent, or you're too old to go for surgery. I think every patient is different, and we need to really go back to the basics and get them ready for all these procedures. I got a question to ask because I've got another patient that I'm looking for doctors to advise me about an elderly gentleman who had AS, and then he was diagnosed with SBE. But he's a businessman, he's otherwise very well, and then the family is now deterring as to whether he's too old for any valvular replacement procedure. He's still old, he's still young enough to nag his wife and scold her every day, and he walks around even though he's 90 years old. So I would love to ask the group for your wisdom on this.
Maybe Vincent can chime in. Vincent has probably a good view of, he's an imaging expert and also very keen educator. He hits the postgrad program, and I'm sure he gets a lot of these questions from a lot of people. So Vincent, what do you think? Elderly patient, endocarditis, aortic stenosis.
I think from the imaging point of view, that I think both in valvular and even in amyloid, we are able to image patients pretty well, even if they are elderly. I think traditionally a lot of advanced techniques like MRI or CT is always a problem with cooperation, like breath holding, etc., during the scan in order to get diagnostic results. I think with advances in technology, for example, like CT, we can get really good images of the heart, which is essential for TAVI planning. And for MRI, in terms of like amyloid, I think one of the common things we are concerned about is renal impairment. Patients with amyloid, especially in the elderly, low eGFR, whether we can give them gadolinium contrast. But I think as Wan Xian has mentioned earlier, with mapping techniques, these are actually typically non-contrast, and we can get pretty good diagnostic information even without contrast, gadolinium contrast, if we don't want to. So I think definitely from imaging point of view, there are a lot of advice.
I think Vincent's connection is a little bit affected there. So maybe I'll just say that the Carol's question on endocarditis is really challenging. I think if for these patients, I don't know what, maybe Kaywood can also put some of his comments, but certainly if we want to treat these patients aortic valve, we definitely have to clear the infection first because of the risk of having a prosthesis infection. So maybe Kaywood, you have kind of experienced this before.
Yeah, thanks, Edgar. Thanks, Carol, for the excellent question. Yes, we do have these patients coming to us for TAVI when they are really at high risk. The balance is whether we can successfully put in a TAVI valve and consider whether there is any ongoing infection. What is the risk for recurrent infection with a history of subacute bacterial endocarditis after successful TAVI implantation? So we must be really sure that the patient is not a candidate for open surgery, and the infection is as treated as we can. If possible, maybe a little bit of time between treatment of infection and TAVI, so as to allow to see whether there is any recurrence of infection before TAVI is carried out. So in such high-risk patients, yes, TAVI is an option, but we always have to balance with the risk of recurrent infection.
Okay, so we're really coming down to the last minute. I would like to probably just get Matthew. He's probably the youngest of our team, and want him to just kind of tell us what he wishes to see in his generation for the field of Geriatric.
Thanks, Edgar. So indeed, I think there's a lot of opportunities for collaboration in the future, right? Even as we talk about things like sarcopenia and all that, I think that there is really a strong role for involvement of a multidisciplinary team, right? Besides looking at nutrition, we should be looking at function as well as I think really rethink the way we actually perceive aging, right? We need to reframe what aging actually is, right? As we are looking at, like, for example, the guidelines, that we were talking about, discussed at like ESC and all that, that there's still that talk about chronological age, and when in fact we've already gone past that, and we are really talking about biological age, right? We're looking at things like frailty and all that. So perhaps this is really where more research can go into, really looking at the interface between what we see in clinical practice versus actually what is really happening in the research area, and translating that over. The other thing is actually also asking ourselves, because we're always talking about interventions and wanting to do more. But one thing we need to ask ourselves, or at least take stock of what's going on, is really asking ourselves, what does the older patient actually want? What are their goals of care? Because the chance is that sometimes we may run the risk of having therapeutic misalignment, right? We have so many gadgets, armaments, that we can dish out on the patient, but is this really what they want in the future, right? So having that goals of care discussion will also be very important, and I think also highlights the importance of interdisciplinary collaboration.
That was very well summarized, Matthew. Thank you very much. I think that really sets the tone, I think, for being a clinician and being putting the patient really at the heart of everything that matters to us. So with that, I would like to actually have to end this already. This is the QR code for our participants. Please use it to claim your points, as many of you have journeyed over the past, more than an hour with us. And with that, I'd like to thank everyone, especially our three speakers and our panelists as well, for spending this precious Saturday with all of us. And also, I'd like to thank, of course, our sponsors, Pfizer and Edwards, for supporting our educational outreach. And I look forward to seeing all of you again. So stay safe and have a great weekend. Bye-bye.